comments, and I can always pass the mic around too, or comments or questions, or it's fun passing the mic around. Yeah, great. Here, and maybe name as you go too. That'd be great, and possibly where you work. If it, no high bar or anything. Yeah.
My name is Teresa Shaughnessy. I met Hirpal last week at the Quality Forum, and I've just finished the Quality Academy at the BC Safety Quality Council, and that's who put me in contact with Hirpal. I work at BCIT. I'm a nursing instructor, and we're going through a big curriculum rehaul, and I am tasked with embedding safety quality competencies into our new curriculum, which was a big focus of my project with the Quality Academy. One of the keynote speakers at the Quality Forum last week, I can't remember his name. Remember? The gentleman from IHI. He talked about burnout and and the burnout and the big reason for lack of caring and following the medical model. Yeah. So his solution was to give trainees or students the tools for quality improvement. And I've gotten a bit of backlash from Cousin about embedding quality improvement into nursing education, because I think the more tools nurses have for quality improvement will give us the confidence to fix some of these things.
Yeah.
So research is good, leadership is good, but if we don't have those quality improvement skills that people in professional practice or management have, because they're fixing our problems for us, what do we do about that? And what's your sense at UBC, because I think there's a lot of educators here from different programs. We are embedding a quality improvement course at BCIT next year. That took a lot of push.
Good for you.
I think it's time. And to take nurses away from the front line to be involved in these quality improvement initiatives. That's once we educate them.
Excellent. A big hand. I think that was just a fantastic comment. Thank you. Probably the rest of us are way behind, so in terms of quality improvement, and I guess I couldn't agree more about have the people who are on the front lines of care delivery, whether they're students or new grads, get them engaged in that conversation. And the only thing I would add is keep an ethics lens on the quality improvement as well. So thank you so much. That's inspiring. Yeah, Hirpal.
I think what I would add to that, Teresa, is we need to look at how we move from power structures that are hierarchical to power structures that are leveling.
Absolutely.
And so none of that work happens, and unfortunately nurses traditionally find themselves here on the power structure. And part of it is the way that we're paid, right? Most of us are paid by, the provincial government, right? Whereas our physician colleagues are basically small businesses, right? And that totally changes what our power structure and what we can say at the table, right? And so I think, Teresa, what you talk about is very good, but collectively as a group, I think we need to look at who holds the power, why do they hold it, and all of us should be holding some part of that power.
Can I add just one point to that, and we'll go. I see a hand over there and there.
Yeah.
Just also a salient example to look at that I meant to mention earlier is the Mid-Staffordshire Trust crisis, which was in England, and a prolonged period of reduced funding. This is the really Coles Notes version of it, but reduced funding, reduced RN staffing, and serious challenges with quality of care, demeaning of elderly folk, patient safety problems that blew up. There were about 5 different reports on it. So Mid-Staffordshire is the equivalent of a health authority. And part of what they found was that the hierarchical structure was absolutely what you're saying, not listening to people on the front lines. And also were repeatedly, this is the part that I was so glad somebody named, the repeated reorganization meant a loss of corporate memory, organizational memory. So that the ability to keep initiatives going was really hampered. And I really agree with the point about involving nurses in moving that forward. Thank you. I saw your hand over here, so thanks.
Hi, I'm Christina. I work with at BCH, and I also work in the ICU, still casually, and I used to teach for BCIT for healthcare. Anyways, what I was going to say is, with regards to what you were saying, Teresa, I think your name is, I think quality improvement in undergrad studies for nurses is a really great idea. I'm surprised you got some pushback against it, because I know Angara also does their project, their change project thing, which I think a lot of areas in healthcare, VCH at least, has really been embracing, and a lot of units and different areas have been saying, like, we want more of them, they're really passionate, they're really engaged. And I think from a ministry lens, having worked with BC Patient Safety Quality Council, as you have, the Releasing Time to Care project is another really good example of how we're trying to empower people who are frontline workers in order to be involved in quality improvement, and the new Quality Academy for clinicians is another one. So I think we're moving along those lines, and I've seen also at unit levels that there are some managers who are forming a lot of informal work groups. So again, frontline nurses, can you guys be a working group for workload, or can you be a working group for anything else, like how we can make our breaks better, or how we can be more efficient, that sort of thing, and also getting paid for it, I think is like encouragement for what you're doing in your program. And also to what Hirpal was saying about physicians getting paid differently than nurses, I think what we heard at the Educator Network Day that just happened, and we had some physician speakers there about engaging physicians in quality improvement or anything like that, was that there are a lot of physicians who want to be paid on the same model as nurses, so they want to be staff for the hospital because that gives them the benefits, and they'll be able to have a better work-life balance. So I think things are starting to go in that direction, and I think if we continue pushing and letting people know about it, and giving people the opportunity to actually have those structures in place, that more and more people will come on board.
Yeah, great. Great. And what you're really talking about is grassroots, right? Which is where, because sometimes what happens is the initiatives are coming from up here. By the time they hit here, people are like, this makes no sense to us, right? So how do we work so that our grassroots is also informing up, so that it all makes sense when it actually comes down to the patient, ultimately.
And what you're both pointing to is the power of a good example as well, really, because it can be exhausting to look for and see more and more problems and challenges. That seeing something go well is enormously energizing, particularly, as you've said, when it's grassroots up. So finding out from each other what works, what's been trialed, things like safety huddles. Why don't we could turn those safety huddles, which I understand have had a fair bit of effectiveness depending on how they're deployed. For example, we could have ethics huddles, or I'm feeling awful huddles, or something like that, to be able to support each other better.
Yeah.
Other hands.
The notion of moral distress is so related to values, and I think there needs to be values clarification work and values education work. My worry is, because I'm really interested in new graduate nurses, we know there's a socialization that happens with new grads. We have high attrition, and some of the people that end up leaving the profession are those that are morally distressed. My worry is, what about that group? What about that gap of the people who don't become morally distressed? Because if you believe that values are dynamic, which is a place that I work from, and that they've adjusted their value system, or they've become morally disengaged. And so if we don't start early, what we could end up with, we're talking about those that are morally distressed, but what about those that aren't morally distressed, that stay within the environment? So I just think there might be some work there that we need to think about. I also just wanted to talk about the notion of being person-centered. I think we often talk about patient-centered. So, and that's a really important thing. But sometimes the worker is lost there, because we think about the worker as being important because it affects the way the patient is cared for. But if we think about it from a person-centered perspective, then we care about everybody that's within an environment.
Awesome.
And so it's not just because they care for patients, it's because they're a human being, and we should be person-centered and being worried about them. So I just want to just add those things to the discussion.
It's very interesting that you mentioned that, because places like ICU, places like the ER are absolutely those environments. And one of the reasons I ended up leaving ICU was because I had a man who was here on holidays. I'll make this really brief, with his wife. He suffered a massive heart attack. We put him on a ventilator. We put him on inotropes. And it was realized that, this man is not going to live off this ventilator. And so this woman was here with no support. And we basically turned off all the alarms at the bedside, but in ICU what we do is we keep the alarms on at the desk, the nursing desk. So I stayed with that wife, and I, helped her, and I'll never forget her telling her husband, go in peace, go in peace. And I sat with her, and I remember crying, and I'll never forget going back to the nursing station when it was all over, and having the nurses laugh at me
Laugh.
because I was crying. It was like, what do you think you're doing? And it was like more like toughen up. And I can tell you what that did for me on I left. I left shortly after that incident because I was like, this is not what I signed up to do. But you know, part of what and I don't think those are bad nurses that did that. I think they did that because that's how they survive. With a mortality rate that we experience in ICU, they toughen up. And what happens is when someone like me comes, I don't fit in, right? And it was too hard because I was fairly new in nursing for me to stand my ground and stay there and make a difference then, right? But we have that happen every day, and I think in areas where we have high stress, like the ERs and the ICU.
Again tonight. I guess I'm thinking about that I've actually restarted a nursing career at the bedside in labor and delivery at Women's Hospital, which has been very exciting. I've been an educator for 13 years, so to go from educator to learner has been a real shift in my paradigm, obviously. And one thing that I think about is I always think about nurses as leaders. I think that's when I came into nursing, is that was very much pushed, that we're these political activists and that we're leaders. And something that's really helped me is actually to understand I'm also a humble follower, you know, and that in my desire to be safe for the patient and understanding even a nursing model that can buck the medical model to deliver the safest deliveries for women, I have to humbly follow the medical profession who are making big adjustments. I have to understand that midwives are making these big shifts, and that so that actually we're all part of it together, and that to be oppositional doesn't help either. You know, and I went to this interesting talk, I'll just be really brief, but I went to a talk this morning about UBC, put on by UBC, and it was looking at the studies from a medical journal saying that home deliveries were unsafe, comparing it to a study from a midwifery journal saying that home births were actually very safe, and that it was just looking at how they compiled the data to perpetuate the values that come from those places, you know. And I just thought, oh, it's too bad that we're opposing. Like, why aren't we just following and helping? And I think maybe just at Women's is kind of getting there, but I don't know, I just like that idea. And I have my own visions of what a good birth is and what that means. But actually, who am I there for? I'm there for this woman. So if she wants the medical model, then that's what I have to help her with and just be an advocate and be ethical in that. So anyway.
You have to be very careful about throwing our way of knowing, which is the almighty biomedical model, at people and not listening to them. I mean, the question, like I said at the very beginning, is, do you want to be saved? Do you want the treatment? Does it fit with like where you are in your life right now? Like we rarely ask that. I know I've got a really acute care background. We rarely ask people that. We're like, okay, yes, let's go. This is what we're going to do, because we know what's going to make you better. But then we never stop to ask the question, do you want to be better? Right? And so I hear a little bit of that in what you're saying, and then what you're saying is let's stop and ask people what they want, and not suppose that what they want is what we want. They might not.
Thank you.
Yeah?
I think that's ours.
Okay. Yeah.
So I think the final word is us giving all of each other a hand. Thank you so much.
Thanks, Paddy.
Okay.
I would also like to thank Paddy, who has very generously, from the very first phone call that I made to her, saying, here's the kind of work I'm trying to do, who's just said, I'm on board. It's like, you know, she didn't even say, well, like, who are you? And like, you know, why are you not attached to some kind of organization? Right away, like she's like,
always a good thing to be.
I know. And so I want to thank Paddy for all her hard work from the very bottom of my heart, and thank you so much for sharing your wisdom with us.
Thank you.
Okay?
Thank you.
Thank you.
Thank you.
Yeah.